Hello, and welcome to today's health webinar. This episode is brought to you by our friends at Lumeris. We would like to remind you that the Q&A feature is available, so feel free to send in your questions and comments throughout today's webinar. We would love to hear from you. And with that, I will turn it over to our moderator, Brian Flanagan.
Thank you, and welcome everyone. Appreciate you joining today's panel on unlocking innovation with rural health transformation. I'm Brian Flanagan from Lumeris and will serve as your moderator today. I'm joined by a dynamic collection of healthcare industry leaders from the Collaborative for Healthy Rural America. The CHRA was founded last September to help states and rural health providers capitalize on the $50 billion investment opportunity by the federal government to radically improve access, quality, and outcomes in our U.S. rural communities. We're going to try to make this fun and dynamic and fast-paced today. We're going to have a couple of polling questions. We would really encourage you to submit your Q&A. We'll do the best to cover the landscape here. There's a lot going on with the Rural Health Transformation Program across the country. We have over 400 people who have signed up for this webinar from really all facets of the overall health economy. So looking forward to the webinar today and appreciate your participation. So let's go ahead and jump in. We're going to start the first question with Alice from Unitas. Alice, thank you for being with us today. You've spent your entire career in public health policy, and so it'd be helpful. What is the Rural Health Transformation Program, and why does it present such a generational opportunity for our U.S. healthcare industry?
Yeah, so thanks, Brian, and I'm really happy to be here with you all today. So as you mentioned, the Rural Health Transformation Program is a federal-state partnership that will invest $50 billion of federal money over 5 years, with the key goals to strengthen healthcare delivery and then improve health outcomes in rural America. $50 billion is actually an extraordinary commitment of federal resources going to the states. Just to quickly put that into perspective, many of us remember HITECH. So the HITECH Act invested about $29 billion over roughly a decade to accelerate EHR adoption across the country. The rural health transformation is obviously much larger and will be deployed in half the time. So definitely a bigger lift. But what I would say is most important isn't just the amount of money, it's actually what CMS is trying to accomplish with these funds. So rural healthcare, as we know, is at an inflection point. Providers are facing workforce shortages, financial instability, access challenges, and then, of course, patients with increasingly complex needs in these areas. So with this program, what CMS is looking to help states and rural providers do is really to modernize the care delivery, improve coordination across health and social services, strengthen financial sustainability, and then ultimately improve outcomes for our rural communities. It's an enormous opportunity, obviously, but that is not without its great challenges. So I think that's what makes this moment particularly significant, is that it comes at a time when states and providers are also looking at a slew of other issues. So potential Medicaid funding reductions, and then just facing increased fiscal pressures in general. Our rural providers have always operated on thinner margins than their urban counterparts, so getting this investment right is really critical. I think every dollar needs to be allocated strategically to build those capabilities that really can improve efficiencies and strengthen care coordination while focusing on that long-term sustainability. It's not an easy feat by any means. So CMS and states and rural providers will definitely need to move faster than they've ever moved before, and they'll need to design programs, stand up infrastructure, measure the outcomes, and demonstrate impact all on that pretty accelerated timeline. So it's a huge program. It has a lot of challenges, but the opportunities are really great. And if executed well, I think this investment, it definitely has the ability to strengthen rural systems far into the future, for sure.
Great. Thank you, Alice. Appreciate you getting us started off with those insights. We're going to go to our first polling question. So, coordinator, if you could pull that up. With looking at a program of this size and magnitude, we're reminded of the healthcare triangle and the balance across access, quality, and cost. So we're really interested in the audience's view on what's the most important objective of this program, knowing that a lot of times access, quality, and cost are in conflict with one another. So while the answers come into the polling question, Dr. Farah, we'll move to you. As Alice mentioned, the $50 billion in funding is intended for providers, particularly in light of the Medicaid cuts in the big beautiful bill. As a family physician and as an industry leader who has significant depth in clinical operations and technology, what are you seeing? What are the challenges and opportunities as it relates to the Rural Health Transformation Program for providers?
Yeah, thanks, Brian. And I'll look at it really from a rural health perspective and rural health provider perspective. And Alice hit on a lot of these things, but I think overall, probably the biggest challenge facing rural health today is that we ask rural providers to deliver nearly the same breadth of services as urban and suburban systems, with dramatically fewer resources, lower patient volumes, and persistent workforce shortages. So this all results in thinner negative margins while they're trying to care for aging and sick populations, limited access to specialists, geographic isolation, small IT budgets, and other significant capital constraints. So most rural organizations simply don't have the scale to support traditional care delivery models like we're trying to make them. I think the other thing with our rural health systems is that they're unlike typical community hospitals. These rural health systems are not simply healthcare organizations; they're essential community infrastructure. They're often the largest employer in the community, the only emergency department for miles, and in most cases, the sole source of healthcare access. And so that means when rural health systems are struggling, entire communities are struggling. This all means that the opportunity is enormous, as Alice was saying, and programs like the Rural Health Transformation Initiative are recognizing that rural healthcare cannot be sustained by doing more of the same, but rather there is this ambition for a future that will be built around regional networks rather than standalone organizations, virtual first specialty care, stronger partnerships among hospitals, FQHCs, behavioral health providers, and community organizations. And then there's going to be a backbone of use of technology, AI, and automation to augment the most scarce clinical resources. And I think Alice also mentioned, I think we're seizing on one of the key lessons from previous programs like DISRIP, that transformation funding must create sustainable operating models, not just fund projects. And so the success of this program will depend on whether the investments permanently improve access, workforce capacity, and financial sustainability after the grant dollars are gone. So ultimately, this opportunity is not simply to preserve rural healthcare as it exists today, but to fundamentally redesign it to create a more connected, technology-enabled, and sustainable rural health ecosystem. And as I mentioned, resources tend to be scarce, so it's important for providers, especially our rural healthcare providers and FQHCs, to engage with their state health leaders to understand the opportunities for their particular state so they can align and focus those resources on the correct opportunities.
Great. Thank you, Dr. Farah. You made an important comment in terms of the importance of providers engaging with their state health leaders. Alex, I'd like to come back to you as our policy expert. How are states responding to this program? There's a lot here. There's a short time frame. The scope of this is very broad. We can see here the answers of the polling questions. The leading indicator here, at least from the audience's perspective, is solving the access problem, which we as a CHRA would certainly agree with, and it's the North Star for all of our work and efforts related to the RHT program. But that all three are very important here in managing them contemporaneously, which also sets the stage for the need for doing things differently and doing things on an innovative basis. But Alice, what are the states seeing? What are their challenges? What are their opportunities? What advice do you have for our state health leaders that are in the audience today?
Yeah, so I mean, states are really at the center of this transformation, right? So I think what we're seeing is a tremendous amount of enthusiasm from states. Obviously, the funding that they receive per state varies, but it's in the $200 million range for this first year. So, depending on the size of your state, that's pretty significant. Opportunities of this magnitude don't really come along very often, especially for some of these smaller states. So states recognize that rural communities do face these persistent challenges that you discussed, Brian and Bill, and the provider shortages, hospital closures, transportation barriers, and then growing social needs in those areas. So states really are seeing this program as a chance to address those issues in a more comprehensive way, I think. But at the same time, states are grappling with some significant challenges with this program. So I'm going to name a few. First, I think the timelines are really aggressive. We know that. So it's a large investment that needs to be planned, implemented, measured over a pretty short period of time. So the states really have to develop strategies. They have to align their stakeholders. They have to establish governance structures and demonstrate those results much faster than they may be accustomed to. Second, I think they're being asked to balance innovation with accountability, right? So CMS is looking for meaningful transformation and measurable outcomes, not just simply these incremental improvements, things that can be really sustainable over time, right? So they need to identify investments that can produce those sustainable changes while also showing that clear value to federal partners and to the taxpayers. And a third challenge that I just want to highlight is I think many states are trying to do this again against that backdrop of broader budget uncertainty. And those potential Medicaid funding pressures that we're likely going to see pretty soon. So that raises the stakes really considerably. The goal isn't just to get the money out the door. It's to use the funds to build capabilities and infrastructure that can remain valuable long after the program ends. That's going to be a really key thing, is that sustainability. So with those challenges, I think the opportunity is still really great. States have the challenges to bring together healthcare providers, community-based organizations, state health and public health agencies in ways that have historically been pretty difficult to achieve, especially in those rural areas. And I think the states that'll be successful are the ones that have engaged the providers early, to Bill's point, and that create these kind of strong public-private partnerships, building solutions that are designed around the needs of communities. So I think when Dr. Farah says it's important to speak to your state leaders now, that's critical. So rural providers and community organizations shouldn't wait for the state to come to them. I think this is the moment to engage and really help shape the future.
Thank you, Alice. A lot to consider there for both providers and for states. Kim, I'd like to move to you. You're an industry veteran. You've seen a lot of major trends and cycles in healthcare where there are challenges and opportunities, whether that's the Affordable Care Act or COVID or any of the other major events that we've had over the years. What is your unique perspective on what our RHT has to offer the industry here?
Yeah, I mean, I think an industry veteran, I think you're being nice and saying I've seen a few cycles here, but what that tells me is things aren't getting better in our industry, right? Costs are going up, quality is questionable or worse in many places, in many cases, access is worse. Shortages, are significant. So I think my perspective, at Teladoc's perspective, is that the rural health stimulus couldn't have come at a better time, right? This is sort of what we need right now as an industry to sort of create some shock and awe and make some real change. We don't see it as a one-time event, right? Or as just a way to pour money into existing programs. Like, if we do this right, this is an opportunity for the industry to really do some transformational things, not incremental investments in existing capabilities. A couple examples, maybe CMS has been really clear, and we've been watching them very closely to see how they talk about what they're looking for here and what they want to fund. And I think there's a year one and then a year two and beyond sort of question, where year one will probably feel a little more incremental because, as my colleagues and previous panelists said, it all happened so fast. I think what we're seeing is in year two, there will be a little bit more room for true innovation, and that's what we're expecting to see the states come forward to. But what CMS is going to look for across all of the applications is collaboration in new ways, right? Private partnerships with government, with private companies, with health systems. Like, let's think outside the box. And that's a little bit of where the CHRA came from, right? We got together and said, what does the industry really need? And I think it's really been driven by this idea of, let's solve the right problem, and let's use this as an opportunity to really sort of transform some important parts of healthcare. Finally, right? We've been waiting for this for a long time.
Yeah. Thank you for that perspective, Kim. So you lead strategic partnerships for Teladoc. You did for Livongo prior to that. You've been around a lot of deals, a lot of collaborations. What is it about the CHRA? What is the CHRA trying to achieve? How did it come together? What's your perspective there?
Yeah, so as I started to say a minute ago, I think the impetus here was a group of us who were sort of industry colleagues, coming at healthcare from different angles, started to get together around a table and say, what is this really asking for? What is the core of what innovation would really look like that these dollars could help seed and fund? The dollars alone aren't the whole answer, aren't the forever answer. This needs to be sustainable change, right? So I think a couple of key attributes, guiding principles that we've thought about as we've put the CHRA together are one, scale and speed. Like I said, year one happened really fast. States were asked to demonstrate impact right away. So that's all happening. It's happening in various ways and at various paces across the 50 states. But the ability to sort of turn something on quickly and make it run and make it work with high integrity it was pretty critical. So what are those capabilities? And then what is the combination of assets that, when you put them together, solve our problems that exist in new ways? So I'll give you a couple specific examples. Teladoc Health has a 50-state credentialed provider network. We do, millions of online telehealth visits a year. But that's not enough to solve the rural health problem, right? There are other complementary assets that we have identified as part of the CHRA consortium that, married with our telehealth solution, we think, sort of are an exponential empowerment of telehealth. So Lumeris, for example, with longitudinal AI care orchestration, pulling that forward through and into and integrating it with telehealth. Telehealth over on the side by itself isn't going to solve the problem, but married with something like the Lumeris solution will, unite us as a partner here, offering the sort of community connection and engagement, looking for things like social determinants of health levers that we can use in these communities. I particularly love the self-sufficiency scoring aspect that they bring to it, really giving new insight on populations that the healthcare system uses. It's sort of one of those things that is so obviously important and we sort of forget about sometimes. Deloitte obviously is a leader in the industry. Their knowledge across the states, as evidenced by Dr. Farah's comments, really important and powerful here. And then Instacart, I think back in the category of, it's so obviously true that what we eat affects our health. Let's bring all that together, right? Let's marry those capabilities and think about how states can deliver something entirely new that really cuts across these sort of siloed sets of capabilities, and really delivers sort of health in new ways. I think that's sort of the impetus and where this all came from.
Thank you, Kim. Yes, and that's a very exciting overview of the notion that given a intractable problem and issue and challenge such as solving the rural health crisis, it's going to take a village, and we as a group of industry leaders recognize that, and are really excited about what we've done together and what the future holds. Sarah, would like to move to you. We're delighted to have you be the most recent addition to the CHRA. Food as medicine and nutrition management are critical to overall effective care management of rural population. What's Instacart's focus on RHT, and what are some of the examples of the best practices that Instacart has experience with?
Thanks, Brian. Yeah, excited to be the newest member of the CHRA. And to take a tiny step back, for those who aren't familiar, I lead Instacart Health. We're an initiative that's Instacart, the leading online grocery platform. Sometimes it's like, what's Instacart doing in healthcare? And we are really laser focused on physical and financial access to nutritious foods. We serve 98% of US households with same-day delivery from fresh local grocers, so using the local community. And during the pandemic, that's when we realized that we're a lifeline for millions of Americans. And we use that experience to help understand the power of our platform and how through partnerships like the CRHRA, we can bring not just convenience, but really nutritious foods, especially to rural America. Great example of why, or the how, is our work with the University of Kentucky and No Kid Hungry several years ago showed us that when you pair online grocery with subsidizing just delivery for EBT SNAP families and some modest nutritional guidance, we saw real improvement for those communities and those families. And that was some obvious, some not. So it's time and transportation that you're solving, also reduce stress from the stigma of sometimes using financial assistance, and sticking to a budget. So when we gave families access to delivery, subsidized delivery, and some education, families purchased $6.84 more per week on fruits and vegetables, so per week, and didn't change their budget. So that was honestly like one of the first projects that Instacart Health saw. Oh wow, we really have something here. We can use our consumer platform with some wraparound services to have a real impact. So since that study, for the last several years, we've been working with providers and CBOs and managed care organizations across the country to be that food delivery mechanism, and from managing diabetes and hypertension and high-risk pregnancies. We really allow health organizations to use Instacart in two ways. The first is Fresh Funds, which is our flagship product that lets healthcare organizations customize medically tailored stipends, and it works across our 100,000 plus store network to have delivery and pickup. And we also have a platform that allows any provider to deliver on behalf of a patient, our Instacart Business platform. So those two things on top of the Instacart platform make us why we're at the CHR, or why we're at the table. And we really are designed to integrate food benefit programs into any healthcare program. I think a great example that is our recent announcement with Teladoc. Teladoc has integrated Fresh Fund stipends into their program. It's part of their workflows. They have also made all of their meal plans and recipes shoppable on Instacart. That's making that advice actionable, right? So like, you're not only are you talking to a physician or a clinician, they're telling you things, but how do I actually act on it? You can add it all to cart. I might subsidize that with some Fresh Funds for you. So very excited about that example, and that's why we really are, being part of the CHRA gives us an opportunity to do that with all the members of CHRA, but really connect with states, their health systems, to be that part of that connective tissue, and continue to innovate. We want to be a resource and a partner, not directly, but as part of this ecosystem that's very easy to plug into. So thanks for the question.
Yeah, thank you, Sarah. Very excited to have you aboard. So we're about halfway through the session. So we've heard a lot already. We've heard that there's a lot of capital, short time frame, lots of pressure on states to perform and use the money effectively, lots of pressures generally, and to start with on behalf of rural providers, and therefore the need to be able to receive and utilize the funding effectively, and doing so in a super innovative way that can help deal with these pending cuts. We have had, as a CHRA, engagement with well over 30 states at this point. And generally what we're seeing is the whole industry is working really hard on how best to capitalize on this opportunity, how to deal with the challenges, how to partner, how to think really pragmatically about how to respond. Kim's perspective on year one, hey, we're moving fast. We've got to get the infrastructure in place. This is now really about moving into years 2 through 5 to build that true innovation and sustainable change. And we're excited about that. If we could go to the next polling question, it would be interesting to see from the audience, based on where we are and understanding these challenges, are we where we need to be as an industry from a schedule standpoint? Are we behind? Are we on schedule? In a number of the conversations that we have had, we're hearing that the states need to get through practical things like governance, decision making, managing political dynamics, state legislatures, the governor's office, et cetera, as well as things that sometimes can be mundane but are equally important, like procurement and the complexities associated with procurement, which is just a reality that really the entire environment has to deal with. So as the results for that come in, I'm going to turn to questions for each of the panelists. The same question, and ask each of them to answer based on their insight and perspective and from where they sit. And then we'll go to Q&A from the audience before we adjourn at the top of the hour. So for each of, and I'm going to start with you, Dr. Farah. What is the one insight or one recommendation for how states can and providers can best unlock value, unlock innovation from the Rural Health Transformation Program?
Yeah, I think that the most important thing is to meet our constituents where they are. So when I hear a lot about technology and innovation, there's a fear that, well, this is an unreachable population. And I think what's been really intentional about the CHRA is that we're analog in the last mile, right? We can do everything with phone and text. So even though you're dealing with incredibly innovative companies that use high-end analytics in the background to deliver care, that last mile is all analog enabled. So I think the way that we unlock value is providing services and technologies that meet our constituents where they are and not only fit into the workflow of our providers, but fit into the life flow, if you will, of our patients and members. So, and I think that we've put together, again, very intentionally, a technology ecosystem that allows that in a very nuanced, sophisticated way.
Yeah, thank you, Bill. And while you were sharing those remarks, it came up the overwhelming view that we're behind schedule, and a big part of that is dealing with these this first year transitory period of just getting ready and understanding what is necessary to accomplish, how to navigate the various requirements, and so on. And so we're all hopeful that moving towards year 2, there can be a lot of momentum gained across the states to really take advantage of this once in a generation opportunity. Alice, I'd like to move to you. Your thoughts. What's your one insight or recommendation that you'd have for states or providers?
Yeah, well, I think just kind of coupled with what Bill just said and what you just said, Brian, is that, we have an opportunity right now to kind of set a benchmark, right? And to really show where we're starting from and how to best meet the needs of the folks that we're trying to reach. So one of the areas that we're encouraging states to focus on is using that population level data and community insights that Unitas provides, but coupled kind of with everything that can be provided in the CHRA. With this data, states can develop a much clearer picture of where the unmet social needs are concentrated, where communities are experiencing the greatest barriers to care, and then what resources exist today and where there are still gaps, right? So We can also take that to a more granular level with that self-sufficiency score, and we can get person level data and make that data really actionable, kind of to that last mile point that Bill made of like, what is the best way to reach these folks, right? So rather than relying solely on historical utilization data, anecdotal feedback, I think states can combine the health and social care insights to identify areas where intervention is most likely to actually improve outcomes. I think that's a really good starting place to then focus your investment. So the first year is really about turning broad vision into actionable roadmap. And that's what we're seeing states grapple with right now. Like, what can we actually do to move the needle? So I think that the population insights that I was just discussing help states move from asking, like, where should we focus, to really confidently answering that question of, here's where we can make that great impact first.
Great. Thank you, Sarah. And it's been very impressive to see the Unitas self-sufficiency score, which is intended to understand where the individual is, and then the closed loop referral process to engage with them and the necessary social determinants and other community engagement type services to help improve their health. Sarah, it'd be great to get your thoughts and perspective on the question.
Yeah, piling off of what Alice said too, we obviously love what Unitas does, or helping find the right people to the right care. We can be a piece of that puzzle. And when we focus on RHT, we want to really think about the patient experience, right? I come from consumer tech and grocery, and if we can have a seamless experience that is patient-led, but also trackable, right? Everything we do can be measurable. So in the food is medicine space, of course, we need to get access to nutritious foods, but did people actually use it? What did they buy? How do we tie that back then to feed all of the systems here to make sure that we are delivering sustainable health outcomes and improvements at the individual level, but also at the population level? What are we doing that's working?
Great. Thank you, Sarah. Kim, your thoughts?
Yeah, I think I'll go back to, the framework I talked about earlier, what we're seeing in year one and what we expect to see beyond year one. From the Teladoc perspective, in year one, we're seeing a lot of states turning on telehealth for existing providers and existing patient populations. And that's great. It's certainly more convenient. It certainly gets people access to care in ways they don't have today. What it will quickly run up against, though, is there just aren't enough providers. So telehealth, turning on telehealth doesn't actually extend the capacity of your providers, unless you really are being creative about what kind of telehealth you're using and how you're using analytics and other engagement techniques to give patients access to care that maybe don't require a 12-minute visit or a 15-minute visit. It also, the kind of that year one approach that we're seeing doesn't actually enfranchise patient populations that aren't seeking care today necessarily. Maybe it will on the margin. Some people who couldn't get into the clinic will use a clinic's telehealth capabilities, but really reaching out, finding populations that don't seek care today for a huge variety of reasons has to be part of the year 2+ plan. And so I think what we're excited about is the states we're seeing invest in and think about really novel engagement techniques that build capacity in new ways, leverage modern technology. We see great adoption of, text messaging and cellularly enabled devices in all kinds of populations. And so leaning into that and really thinking about, innovating beyond, a doctor on your phone, right? Really innovating in care delivery is what I think we're excited about and we're starting to see happen.
That's great. Thanks, Kim. So in terms of what we've heard, and this is also some personal editorial based on spending a lot of time with states and providers, what is it that states are feeling and going through? If you look at the RFAs and RFPs that have come out, many of them are highly functionalized, or they're very specific to very narrow scopes of work. Our view as a CHRA is that it's going to be very hard for states to create through a centralized programmatic transformation style program to deliver on the sustainability metrics and other outcomes expectations of CMS to continue getting their funding in through years 2 through 5. So if you're a state who has that concern, we would love to have the opportunity to talk with you about how we could, and this is exactly why we've come together as a CHRA, is to make it easy for states and for health systems to get access through an integrated solution design, which we've created, in order to drive very impactful progress on access and on quality, and over time, doing it at a lower cost of care point, because we've seen through every major population health study, when you institute prevention measures at scale, population's health improve and the lower average cost PMPM goes down. For the provider community, it's interesting, and the topic of this webinar is unlocking innovation. Well, what is innovation? Innovation can often be one of those everyone has a different definition type words. The one that I've found most useful over the years is it's very easy to do more with more. It's very easy to do less with less. It's very hard to do more with less. And so that's what we have to do with this rural health transformation funding. As a country, as an industry, we have to do more with less. And so as we look at some of these intractable problems, such as we do not have enough human beings to meet the needs of access to healthcare in this country, and it's only going to get worse. We don't see a way to solving that problem without using technology. Well, if you're a health system or a state that has that clinical workforce problem and it's creating access issues, we would love to have the opportunity to talk with you, because that's why we exist. That's why we've put these capabilities together, is to help you solve that workforce access problem and help your people get the care that they need, either through a telehealth channel, through a AI-enabled care orchestration channel like Lumeris, through a community engagement channel like Unite Us, through integrated eligibility capabilities that Deloitte brings, through Food as Medicine, as Instacart, et cetera. We need to, as a industry and as an ecosystem, pull these puzzle pieces together and do them at scale, and not do them kind of on a death by 1,000 cut approach. We just won't get the value and impact out of this once in a generation funding if we do so. Okay, so we're gonna stop here with the core of the program, and we're gonna move to some of the questions from the audience. Give me just a moment here to skim some of this. What are the most critical quick wins that states or providers today could target in the next 90 days to build momentum? Kim, do you want to take that one for us?
I'm sure. I have some thoughts. I'm sure my other co-panelists may as well. We're seeing a lot of states talk about augmenting, particularly specialty care, with telehealth capabilities. So, what the biggest, most urgent kind of probably access challenge is cardiologists, endocrinologists, subspecialists in rural areas. There just aren't enough, and there's not enough appointments, and people can't get to the appointments even when they exist. And so thinking about telehealth as a path to solve that is something you can turn on pretty quickly and get more people in care. There's also a lot of people who are getting subspecialty or secondary care today and using up those spots that maybe could have solved that another way. So putting in some triage and some access that gives them alternatives. We send a lot of people in this country to urgent care in the emergency room because we don't have a better answer for them on how to figure out what's going on or get care. So let's not just scale up capacity. Let's actually figure out how to throttle and direct the capacity appropriately and get people into alternative pathways that can be resolved through those alternative pathways, I'll say.
Yeah, and Kim, maybe a follow on to that for Teladoc specifically. So during COVID, we saw this huge uptick in telehealth utilization for all the obvious reasons. We've now seen, as COVID is, not the same level of utilization engagement, and that, of course, was to be expected. There have been a lot of advancements in the care model, and now with the introduction as well of AI and care orchestration and meeting the patient where they are. What's your view if you're for the providers in the audience that are thinking, well, telehealth, yes, they have access points, they're a network, they have the provider resources, primary care, behavioral health, specialty health. How should the provider community think about what telehealth is offering in light of all of that from an RHT perspective?
Good. Yeah. I mean, maybe I'll just give one example, not from a rural health angle necessarily. It's what we're seeing in our core business, but I think the analogy applies. We offer online virtual urgent care. We do millions of visits a year. A huge percent of those patients could end up in some downstream, either specialist or diagnostic situation. But we have intentionally applied a logic layer that says, hey, what's really going on with this patient? Let's seek the advice of a specialist in that field to determine what to do next, a provider to provider consult. We're able to defer almost 50% of those downstream referrals. So just applying some logic, like I was saying, in that stream, right, in primary care, in urgent care, helping to direct people who really need subspecialty care into the right care and making sure they get it, and then diverting those who really don't need it, but maybe we just didn't know what else to do with them that day, or maybe there wasn't a great alternative. Let's fix that, right, so that we can preserve that, really coveted capacity for people who urgently need that care. That's maybe one example.
Yeah, I think it's a great example. And that's one of the things that we're excited about from a Lumeris perspective, the TOM platform, and the ability to redefine primary care, for example, from what has traditionally been episodic to something that is longitudinal, always on, that supports the care team and takes off a lot of the clinical administrative burden, whether that's pre-visit preparation, post-visit follow-up, medication reconciliation, education, onboarding, different tools that the TOM platform offers, and the cost point of telehealth is and it's one that we haven't seen prior to the advancement of sophisticated AI-enabled platforms like TOM. Thank you for that, Kim. Dr. Farah, so we see a number of questions here about the serious crisis we have with the workforce burden and clinician burnout and not having enough primary care professionals to meet demand and to meet needs. As a primary care physician, family care physician, how do we deal with this? What is this? What is it that the CHRA is offering that we're looking at from an RHT perspective, and generally for this opportunity with the funding? How do we solve this problem once and for all?
Yeah, well, Brian, I think you did a nice job of highlighting that in your closing comments there. This is an acute problem that's only going to get worse. And in fact, it's been a problem we've been grappling with even before now. If you broaden that aperture, not just to primary care, but allied health professionals that support primary care, there's been a deficiency and a logistical problem for a long time. When I was in practice, I loved the patient-centered medical home model. A patient-centered medical home model requires that you have a social worker, a farm tech, a nurse, a diabetic educator, et cetera, on premise with a primary care physician to render the care that's needed for a patient to take care of them holistically. That's just not possible to have those people all in one place physically. And so, you start with the idea that, well, I can put them there virtually. And then you can extend that by a little bit by saying, well, do I need a person to have that initial interaction, or could it be a digital agent that's having some of those interactions? And so, it's finding where do the digital interactions serve to be not only equal to human interactions, but in a lot of cases, superior. We're finding that a lot of our digital agents, unfortunately, are more empathetic than our human agents. And so creating this digital workforce that's extremely empathetic, that's always on to complement our human workforce, I think is the only way forward. And that human workforce even will become more and more concentrated to either centralized services or call center types of services to do that oversight. But I think that, again, I do want to make the point that we're doing this in very sophisticated ways. I know there's a lot of concerns about, okay, if we do all of those things and we have all of these digital agents, are we still being able to reach our patients? Yes, you don't need internet to be reached out to. That last mile just requires a cell phone signal. And if you're in a place where you don't get reliable signal, there are services like FirstNet that we can tap into so that we always can make sure that even from an analog perspective that we're getting quality of service and prioritize service to reach our most vulnerable people. So these analog services, analog ways of delivering extraordinarily innovative technologies, again, I think in a very intentional way that the CHRA is set out to do, is one of our main differentiators. But I think that's how we will overcome this shortage, is first virtual, then digital complemented very strategically by humans in a very intentional way.
It's very well said, Bill. And I think, from my perspective, we will know, like, one dimension of whether or not this RHT program will be successful or not, if we were to fast forward 5 years from now, has this made huge leaps forward to solving our clinical workforce access problem and burnout problem? If it does, hey, we've used the money well. If it doesn't, then we haven't. This problem is so acute and so central to the issues of our healthcare system. We need to fix it. Okay, I think we have time for one, maybe two more questions. Sarah, there's been additional questions on Instacart's food as medicine model, and how Instacart physically reaches patients, where the delivery services might be limited, the food deserts. How do you solve for? There's a lot going on with this issue of getting nutrition, getting food to people who are in need, in most need, and hard to reach places. How does that all fit together?
Yeah, I think so. Instacart as a whole serves 98% of US households, including 95% of food deserts. So we don't serve everyone, but when we talk to states and when we talk to MCOs, we get to specifics, right? We really talk about how can we be the primary? How can we use local stores that are already in the area, sometimes delivering an hour, right, to get to somebody as part of the solution. There are people that might not be able to reach. Let's focus on everyone. And then we might develop, a mail solution or something else that can get to that person. But for the majority of the time, when we partner with orgs like the CHRA and then states or health systems needs, we look at literally exact zip code coverage and households, and like what households can we reach, what stores can we get them from, how do we continue to support the local retail ecosystem to build and create local jobs and create demand. And then for the people that we can't reach, what are alternative solutions? I think food as medicine as a whole talks about, like, at the baseline being SNAP, like EBT SNAP, and how do we get people part of, and WIC, how do we get people part of that system? But then it's produce prescriptions, medically tailored groceries, and medically tailored meals. And when we approach a situation, we talk about the what and the how at the same time. And Instacart as the anchor, right? We are the anchor for food as medicine, but we are in no way the only part of the solution to be at the table. But it's a great question.
Great. Thank you, Sarah. Well, with that, I'm going to wrap up today's webinar. I'd like to thank the folks from health for organizing this. I'd like to thank Alice, Sarah, Bill, and Kim for being great panelists today. From a Lumeris perspective, it's been an honor to work with these great companies on dealing and addressing and trying to solve this rural health transformation program. We look forward to helping the industry, helping states, helping providers solve this problem. We're committed to it. I think one thing I would leave the audience with is that we're all very much mission aligned here. This is very mission driven for us to solve this problem for our constituents and friends and rural communities across the United States. Have a terrific rest of the day. Thank you for participating.
Thank you to Lumeris and to everyone that joined us today. Please visit our website, HLTH.com, to catch up on all health webinars and watch the recording of today's session. Join us in Las Vegas, November 15th to 18th for Health USA.